안녕하세요. K치과
Greetings, I'm Dr. Kang Chung-gyu of K Dental Clinic. The reason why evaluation is required before implant surgery is because every patient has different oral situation. Understanding and knowledge on evaluation needs to be done in order to minimize side effect and come up with a high satisfaction surgery result. So I'm going to talk about evaluation before implant surgery and necessary data collection.
먼저 목차를 보시면요.
Let's look at the contents. Diagnosis, treatment plan process will be looked at. Second, diagnosis and treatment plan necessary data will be looked at. This includes clinical image as well as radiographic image. Based on the data collected, bone will be evaluated. Before surgery, for diagnosis, you do oral examination of surgical site as well as overall oral examination. You take clinical photos to record the state and to evaluate the bone. The surgical site, you take many panoramic images. Based on the data, you choose the implant length and diameter and also plan appropriate placement position and angle. Second, diagnosis and necessary data for treatment plans. As mentioned, there's clinical image and radiographic image. I'm going to look at clinical image first. The reason why we take a clinical image before surgery, there's two meaning largely. First, this is to compare before and after surgery in providing explanation to the patient and gaining trust and providing satisfactory outcomes. Pre-image is essential for that. Another point, as you can see, pre-surgery diagnosis and treatment plan and relevant data needs to be recorded for diagnosis and treatment plans. As you can see, before and after surgery, images are taken and recorded, and after treatment, you can provide explanation to the patient. It will lead to high satisfaction and you'll be able to gain trust. If you have similar situation, you'll be able to explain more easily. If there is implant complication, you'll be able to build a solid foundation for providing explanation. In the anterior area, by comparing before and after image, you'll be able to explain more easily. If something goes wrong, you'll be able to understand better what went wrong. In general, when you do oral examination at the surgical site, the points you focus on is ridge shape and keratinized tissue. If there is sufficient ridge amount, it'll be easy, and if there is sufficient keratinized tissue, it'll be easier to treatment and there will be nice prognosis. But if not, GBR or free gingival graft and other complicated procedures may be necessary, so we need to approach it cautiously. As you can see in the image, in the same area, implants are to be placed. On the left, the ridge shape is very nice and attached to gingiva is sufficient. However, on the right, there is severe bone resorption and ridge shape is deformed and a lot of resorption has occurred. Attached to gingiva amount is very lacking. On the left, when you do incision, because it's lower, crystal incision can be planned. On the right, you need to divide the remaining attached to gingiva the same on left and right, so the incision line needs to be made lingually. Also, because there is severe bone resorption, GBR is imperative. On the right, there's lack of attached gingiva, so free gingival graft can also be considered. On the other hand, in the case of left, we can consider flapless surgery as well. In my case, when I take pre-surgery image, if you need multiple implants, you take image from the front, the occlusal surface of the lower and upper, and if partial implant treatment is required in the surgical site, you take an image so that buccolingual area can be shown accurately. On the right, the ridge shape is favorable, so we can easily place the implant. But on the left, GBR or free gingival graft may be needed. Therefore, we need to approach it more cautiously. Next data is radiographic image. The radiographic image used in dental clinic first is standard periapical radiology, second panoramic radiology, and third CT. All three have pros and cons and each have a purpose. The biggest purpose for radiographic image is to evaluate lesion within bone. In relation to implanted treatment diagnosis, bone density and quantity is evaluated, and important anatomical structure is evaluated to avoid it. In other words, mandibular canal or sinus floor position is accurately determined, and this is very important in planning implant treatment. Implant placement position or angle is evaluated, and various abutment or impression coping superior structures compatibility is checked using radiographic image. And you also check bone changes after implant has been placed and for implant lifespan. Periapical view. In the anterior region, more than panax, periapical view is favorable in checking the level of resorption and the remaining bone. After treatment, we also take periapical view, even at recall checkup, to check marginal bone loss, and it helps a lot. Buccolingual relations, you need to take CT for that. Second, panoramic view. In general, when you plan implant placement, you take panoramic view. The most useful usage is to evaluate the length of alveolar bone for implant placement before surgery. During and after surgery, you can also check fixture direction and depths. At regular checkup, you can also evaluate bone resorption around the implant. Panoramic view is used for this purposes. As you can see, basically, in the surgical area, panax is taken and remaining bone length is accurately evaluated. It's 9.5 millimeter. Implant needs to be placed inferior to the bone. And for safety margin with the mandibular canal, a shorter 8.5 millimeter implant fixture was planned. In the upper, sinus wall distance needs to be evaluated. If the remaining bone is 7 millimeter, the recommended diameter over 8 millimeter needs to be placed. Socket lift is done and implant is placed. As you plan, you use panoramic view. However, CT, when you take panoramic view and if it is vague, or if you need accurate information, you need to take CT then. In other words, the inferior alveolar nerve or the distance to the sinus wall is vague. You can take CT to check once again accurately. 3D image analysis. Buccolingual bone status or bone width. You need to take CT to know that. sinus surgery where bone graft is necessary. Before that, you need to evaluate the sinus pathologic condition. So CT needs to be taken to have a successful sinus surgery. As you can see, this is Panax image. You don't know up until where is the sinus wall. And the bone height, in order to evaluate it accurately, you take CT. As you can see, it's only approximately 3.9 millimeter. The upper margin on the Panax was the margin of the lesion. There was very little remaining bone. Using lateral approach, sinus graft was done and implant was placed. Panoramic view was taken. In the placement area, mandibular canal and mental nerve, it was clear. So accurate information was required. CT was taken. Mandibular canal to mental foramen. The path was accurately observed and implant placement slightly lingual was needed. Bone width, buccal lingual distance needs to be evaluated. You need CT for that. Using this, you can choose appropriate diameter implant, and implant position can also be determined using this. Before doing sinus graft, as I mentioned earlier, pathologic condition can be evaluated. As you have seen in number 26 and 16, implants were planned on Panax. It didn't seem to be problematic. However, if you take CT in the surgical area, you can see a lot of lesion and radiopacity was observed extensively. If you do a bone graft here, there's a high possibility of failure, so you need to send the patient to ENT to reduce the lesion or solve the problem first, and then do sinus surgery in order to increase the success rate. Up until now, based on the information gathered through radiographic image and CT, we need to evaluate bone where implant is going to be placed. Evaluation of bone can be divided into bone quantity and bone quality, and I'm going to talk about bone quantity. When you evaluate bone, 3 factors need to be considered: bone length, mesiodistal distance, bone width, buccal lingual distance. These 2 determine the diameter of the fixture to be placed. Bone height, crestoapical distance, is used to determine the length of the fixture to be placed. So this information is gathered through clinical image or panoramic image, CT, and we use it to evaluate bone. Ways to evaluate bone. First, bone length, mesiodistal distance. This can be done using model analysis or within patient mouth. Bone width, buccal lingual distance, can be determined using CT. Bone height, crestoapical distance, can be checked. As I mentioned earlier, you can see on panoramic view. If it is vague there, you can take CT again to accurately assess the situation. Bone evaluation. Let's take a closer look. First is bone length, mesiodistal distance. You can use plaster model or within patient mouth, and you can check using vernier calipers. As I've mentioned, the length between natural teeth and fixture needs to be at least 1.5 millimeter. If you are going to place a 4 millimeter diameter fixture on both sides, you need to have 1.5 millimeter. So a total of 7 millimeter of mesiodistal distance is required. If you're going to place a diameter 5 millimeter implant, mesiodistal distance needs to be at least 8 millimeter. Second is buccal lingual width. So there needs to be at least 1 millimeter of bone buccal lingually to the implant fixture. If you use regular fixture, 4 millimeter diameter fixture, so you need a millimeter on both sides, a total of 6 millimeter of buccal lingual width is necessary. If there's sufficient bone width, you can place the fixture that you want without any problem. But in the below, if there's lack of bone width, in number 5, you place 4 millimeter diameter, and in number 6, where it's lacking, you choose 4.5 millimeter, and in number 7, where there's relatively a lot of bone, you can place 5 millimeter implant. Bone width can help us determine the diameter of the implant to be placed. Last, bone height. Crestoapical distance. It is very important when we choose the length of the implant to be placed. Panoramic image, you evaluate it. If necessary, take CT again and assess bone height once again and choose the implant length that is necessary. There's approximately 8.8 millimeter bone height. You need to place at least 8.5 millimeter, so you need to do socket lift and place 8.5 millimeter length fixture. Let's look at a clinical case and review what we've looked at up until now. 68 years old male patient, and implant was to be placed in number 16. As you can see, the soft tissue is not fully mature. It's 3 months later after extraction. The patient experienced severe discomfort and wanted implant placement quickly, so implant placement treatment plan was formed. Clinical image was taken before surgery to compare before and after and for diagnosis. Buccal lingual sign needs to be shown well for treatment planning. After that, Panex was taken. If you look at the remaining bone maturation is not fully done. Bone height was evaluated. It was 9.1 millimeter. 8.5 millimeter fixture. We can assume that there will be no problem in placing this. After that, CT is taken. The reason for this is you check the buccal lingual bone shape and the thickness. And then you determine the diameter of the fixture and the direction as well. As you can see, buccally, more so than lingually, is tilted, and the surgical area there was not enough width. However, this was a male patient and it was for single implant. Diameter of 5 or more is necessary, so 5 millimeter fixture was planned. GPR might be necessary lingually. Incision was done. As you can see, as shown in the CT, it's slightly palatal, and you can see there's a lot of bone resorption. Palatally, the fixture was exposed, and buccally, it was sufficiently inside the bone, so GPR was done. Bone graft was done, membrane was covered, and suture was done. If possible, soft tissue was not fully matured, so primary closure, in order to get that, modified roll and suture, a type of matrix suture was done. After 3 months, the secondary surgery was done. This is the image. Primary closure is nicely done. If you look over here, the bone graft has healed nicely. Healing abutment is connected, and secondary surgery was done. And after that, prosthesis was delivered. This is Panex right after surgery and after prosthesis delivery. If you take CT palatally, the bone graft is healing nicely. And the implant has been placed in the desired position, and the thickness and the length was what we originally planned. In the anterior area, this patient, 65 years old female patient, as you can see, 4-unit bridge. There was a lot of mobility, so number 12 and number 22 implant was placed and bridge was planned for the patient. Before surgery, clinical image was taken and pre-op image and prosthesis was evaluated. And I checked the level of bone resorption and attached to gingiva. And I took CT. After that, I took Panax. As you can see, in the anterior area, more than Panax, periapical view is more useful in evaluating the remaining bone. You can get more accurate information. Bone length was sufficient, so fixture length was 11.5 millimeter. On CT, the reason why we take CT is to check the buccolingual bone thickness and to determine the appropriate diameter for the fixture to be placed. By checking the CT, you can check the bone and set the entry point and direction. If you look, bone width in number 12 is 5.1. And in 22 is 6 millimeter. In general, if you want to place 4 millimeter fixture, the bone width necessary is 6 millimeter. In 5.1, maybe you can consider 3.5 millimeter fixture, but as you can see, it's a bridge. So if possible, for implant stability, choose diameter 4 millimeter fixture. In that case, in the remaining bone, you have to place it centered to the remaining bone, and buccal side, the GBR may be needed. The entry point and direction needs to be checked. If you look at the arrow, the remaining bone, if possible, you need to go as center as possible. More than apex, slightly more towards the palatal. The entry point should be set that way. And in number 12, it needs to go similar to the direction of the natural tooth in order to place the implant center of the remaining bone. In number 22, rather than the direction of the natural tooth, you should place it more buccally so that the implant goes in the center. You can do this relatively easily. First, as you place the implant, use parallel drill to check direction, and 4 by 11.5 millimeter fixture was placed. After placement, in my case, I always take CT because if you don't take a CT, you might get undesired direction, and the prognosis can be bad. Therefore, take the CT. And you can see that the implant has been placed in the center of the desired position. There's very little bone buccally, so GBR should be done. First, GBR was done buccally on both sides, temporary. In order to do it, one-piece abutment, rigid abutment was connected, and temporary was completed. Immediate temporization was done and immediate implantation was conducted. Finally, final abutment. The placement direction was not favorable, so customized abutment, one-fit abutment was used, and prosthesis was completed. As you can see, by recording post-op image, you can see that compared with a pre-op image, the results are much more aesthetic, and you can share that with the patient and gain trust of the patient, and patient satisfaction can go up. The X-ray was taken to compare before and after, and on CT, GBR area and on the buccal side, it's healing nicely. Up until now, I talked about diagnosis and treatment planning process. In the oral examination, you take a clinical image, and for accurate bone evaluation, you take x-ray, and based on the gathered information in the surgical area, you choose the implant length and diameter. And that is necessary. Also, appropriate placement, position, and angle needs to be chosen for optimum outcome. When you build a building, the most important thing is to have a solid foundation. You need to fully understand the basics, or else everything might crumble. Pre-op evaluation, bone evaluation, and data gathering is essential. I hope you understand the importance of it. I hope you review what was discussed today, and next time I'll come back with an even better lecture. Thank you for watching.
함께해 주신 여러분 감사합니다.